Welcome to Dateline Health. This is Fred Lippman coming to you from Southeastern University, and we're in the Innovation Center, the Alan B. Levan Innovation Center, which is a combined effort on behalf of NSU, Southeastern University, and the Broward County Commission. And today we have a wonderful guest, someone who I have a lot of respect for, and is a fellow pharmacist. Don't forget, that was my first profession, was pharmacy. And so let me introduce you to Dr. Goar Alvarez. Welcome, Dr. Alvarez.
Thank you. Always a pleasure being with you, Dr. Lippman.
Thank you. You know, we have so many questions that come. We're fed with mostly questions and issues that come from the public, and people are very concerned about what the heck is going on with, this is the way I would say it, on the streets of Brooklyn, New York. What the heck is going on with pharmacy? What I'm saying to you is that people just don't see pharmacy the way, the beloved pharmacy that they used to see. And I'm not talking about, we all know about privately owned pharmacies and having the so-called chain store pharmacies or multi-corporate entity pharmacies. But I think it's the feeling is that something's going on in the industry that is odd to the people who are asking us questions. And that's why I wanted to get you on, as not only as a very well-known pharmacist, but someone who has served us in the state of Florida on the State Board of Pharmacy and things of interest in many committees. So that's why I have you here, Goar Alvarez. Thank you so very much, Dr. Goar Alvarez. So let's talk about how has the integration of digital health tools impacted community pharmacies?
Digital health, well, there's been a lot of changes as a result of the digital health. So we can even start with the electronic prescription, which has kind of created a benefit for the most part, I think, is that electronic prescription, because as you know, Dr. Lippman, in our day, we spent a significant amount of time just trying to decipher what the physician had written on that prescription. So now that is, that has been removed, if you will. It's all typed up nice and easy to read. So that's one digital health component, but there's also the new apps, which are great tools for consumers, for patients to be able to access. They have access to resources that they can, health information, if you will. They can look, make appointments with their pharmacist. They can request their refills on that app. So many different types of benefits, I think, to some of these digital tools, if you will. But this is on the consumer side, and then there's also benefits on the pharmacist side as well.
So I would assume, and I'll let you agree with my assumption or disagree with my assumption, that the electronic prescriptions have changed the workflow in the traditional pharmacies.
Absolutely. So I think we used to spend a lot of time just trying to clarify prescriptions. That is obviously, for the most part, been removed. The only thing I get concerned about with the electronic prescription, to be honest with you, is ensuring that the patient always has the right to choose to get the paper one if they so choose, or to choose the pharmacy that they want to have that electronic prescription sent to, which is always a concern for me as a pharmacist, that, that it could go one way or the other. But other than that, I think it's actually a very good tool. The tool is actually very beneficial for the workflow and certainly does reduce errors for sure.
There's no question that the issue of electronic prescriptions does also, because it makes it easier for the pharmacy, but there's, and I might be just an observer, but it seems to be less communication other than what I would call print information between the pharmacist and the receiver of the prescription. You know, unfortunately, we have too many people who waive their rights to have knowledge on their prescriptions. You know, I mean, you and I have discussed this for years about people just coming into a pharmacy, getting their prescriptions up front from a non-pharmacist, and then it says, do you want any further, basically I'm saying, do you want any further information relative to the prescription items, et cetera, and they waive it, even though they have a right to have it. You want to discuss that?
Sure, and that is a big problem. It actually started as a positive. So the original intent of that law was over 90, as you remember. It was because it was actually to make sure that the patient was offered the ability to be counseled by the pharmacist. I think somewhere along the line, the profession felt like if the patient didn't ask for it, they weren't going to get it. And I always try to impart on our students that we absolutely have the right, not only sometimes the duty, to counsel our patients proactively, regardless of whether if you feel as a pharmacist that that patient needs counseling about something about their medication, just do it, right? So just go ahead and provide that counseling to that patient proactively. You don't have to ask. If you feel that they need that, you don't have to ask the patient if they want to be counseled. But that's become the...
Let me ask you, I know that there's been a shift. I mean, I guess there are corporate issues with all the large, shall we say, corporate pharmacy entities. A lot of them are closing early. A lot of them are shutting down. What's going on relative to the delivery of prescription drugs?
I think it's a combination. I think it comes down primarily to a compensation issue. So, as you know, compensation for pharmacy services has been, I'm talking almost, so for the dispensing component, for the amount that a pharmacist gets reimbursed or compensated for the dispensing process has been reduced significantly by the pharmacy benefits managers, you know, the insurance plans, et cetera. So it becomes more and more difficult to provide long, you know, extended hours to be able to provide that sort of service on that level of compensation. So I don't think they have too much choice in many instances. That I know that there are different models being explored right now by those by the big companies, the CVS's and the Walgreens of the world. They're exploring ways to create more of a health hub, if you will, healthcare hub within their pharmacies. So reducing the number of dispensing and going into some of the other primary care or secondary care type of models where they're bringing in physicians or nurses or physician's assistants into the pharmacy to provide those services, and then ancillary pharmacy services as well. But yeah, I think it comes down to the reimbursement of the compensation.
Well, you know, you just hit on you really hit on one area, and maybe it's because you and I over the years have discussed this whole issue about PBMs. Explain to the folks who are watching us what a PBM is.
So the PBM, so it's called the Pharmacy Benefits Managers, is basically a middleman. And so the original intent of the Pharmacy Benefit Manager was to go out and create a network of pharmacy providers that would be willing to accept the fees that were being offered by the different insurance companies, and then to adjudicate the claims once it was done, so to be able to adjudicate the claims electronically. So that was the original intent of the PBMs. But what occurred was, I think over time, is that the PBMs contained all of this data, right? So they started looking at, okay, there is some reimbursement from the low-cost generics, for example, or there is a high reimbursement for specialty drugs. So they started creating their own entities within the PBM, which I think is, to be honest with you, a problem from a competition perspective. But they created their own mail order pharmacies and they created their own specialty pharmacies. So whatever was profitable was being taken care of by the PBM, and whatever was left over was being taken care of by the community pharmacists that could not afford at that point, or still happening to this day, could not really afford to be able to dispense the medications at the fees that were being proposed.
You were on the board of pharmacy at the time when we created the certain standards for pharmacist assistants, correct?
Like the technician, what we call, pharmacist assistant, technician?
Yes.
Yes.
And in certain states, and there's a number you can have per pharmacist, correct?
Correct.
What's the number?
Right now it's 1 to 6. But it's just increased, as a matter of fact, for those central fill. I think you're talking about central fill pharmacies.
Yes, that's what I'm saying is that some of the filling areas of these pharmacists are moving to states where they have a huge number of these individuals that are not, in quotes, licensed regular pharmacists.
Yes, yes, and I personally have, so right now they just increased the ratios right now in Florida for central fill pharmacies, for those pharmacies that are doing those types of, heavy duty volume dispensing, to 1 to 12.
Yeah, because a lot of folks, they enjoy not having to go to their local pharmacist, whoever it might be, or the chain store pharmacist, whatever. But they like to just get onto their computer and say, "This is what I want." Boom! It comes in through FedEx or Amex or whatever it is.
Absolutely, and I think that's the downside to that type of service. The mail service is you miss that relationship, right? Obviously, your pharmacist is not available because you're getting it. I mean, like everything, it has its pluses and minuses. What I truly believe is that the best system is one in which the consumer or the patient has the choice to be able to go wherever they want to go. Whether if they want to do mail order, that's fine. If they prefer going to their pharmacist, that's fine. But in regards to the discussion we were just having about PBMs, one of the things that they do is to incentivize the patient to use mail order by reducing copays. That doesn't necessarily mean that it reduces the expense of the medication. Sometimes I wonder if it really does, right? It reduces the expense of the medication to the patient because they steered that patient to that mail order. But to the health plan, it still costs the same or perhaps more. Okay. So at the end of the day, we pay for it one way or the other, right? Either we pay for it by increased premiums, or we pay for it out of pocket by the copay amount, right? So these are some of the challenges. And we miss the ability to have that relationship with our pharmacist that is a counselor that we can go to help us understand our medications better. So that's a dangerous part of the mail order component, in my opinion.
Getting to that area, what recent regulatory changes have had that significantly impact the community pharmacies?
Now, that part I am really excited about, because there have been these are regulatory changes that we've been trying to move for many, many years, as you're well aware. But over the last 3, 4, 5 years, there have been significant changes in the regulatory landscape for pharmacists. So pharmacists can now enter into agreements with physicians, developing care plans together through collaborative practice agreements where a pharmacist can help. So the pharmacist now can become a more integrated component of the healthcare team, where they're actually managing patients with certain chronic diseases, such as diabetes or hypertension or high cholesterol or asthma, or, you know, there's a myriad of different chronic diseases that a pharmacist can now manage in collaboration with a physician. And we've actually started doing that here at NOC, by the way. So we are now, we have some pharmacists now that are embedded. So we'd like to do it in two different components. So we have pharmacists that are embedded in physicians' offices doing that. And we'd like to now expand it so that pharmacists can do it within the community pharmacy.
Well, that's very valuable. I believe it. I know your work in that area, and I commend you. I think it's very important. I think the addition of and the knowledge that we place in the educational values of pharmacy teaching and receiving information gives the pharmacist that is graduating today a great deal of opportunity to help this shortage of what I would call primary care physicians. Do you agree?
I agree. So so as we know, it's sometimes over. So let's say you just touched on a great spot right now. So we know that there is a significant deficit, if you will, of primary care providers at the moment, right? So what happens when a patient has, so this is a new regulatory change that just occurred as well. So right now, if a patient feels that they have a sore throat, these are your scenarios. You call your physician and you make an appointment, and typically they say, well, we can see you in a week or two. Or then you end up coming to the emergency room or the urgent care at a significantly higher cost. Now pharmacists can screen for that right now in the pharmacy. They can screen for certain acute minor conditions such as strep throat or the flu by doing a simple test and assessing the patient as to whether they have this condition and provide treatment for them based on a protocol with a physician. So I think that would help to reduce healthcare costs in general. So now the patient doesn't have to go to the emergency room to take care of a sore throat. Emergency room can now take care of real emergencies. Sometimes they're overwhelmed with these simple things and they can't see the real critical things that they need to see.
Well, I think that was probably in my, most people I know that, or I've told them, I will tell them again, my first profession was pharmacy. Then I became involved in education. But I am so pleased that the patient care services issue have been viewed, and because I mean it's really sad. I hear it all the time. I want to make an appointment to see my doctor, and they tell me well, it'll be 2-3 months. Well, you know, 2-3 months is not the answer that you should give. You know. You know, maybe it's my age. I come from an era when the general practitioner was available immediately. In fact, where I was born and bred, in the center of mankind, Brooklyn, New York, the doctor would come to your house. It's just it's really wonderful to know that patient care services, and I'm glad that the legislatures. Particularly, I'm very pleased that your hard work, like I said, at the Board of Pharmacy and through the organization of the Florida Pharmacy Association, have gained access to having the legislature react correctly, I believe. I think correct is the word in my mind. your mind?
I think, so imagine, if we truly utilize the ability to collaborate with physicians, how much better, our patients, our healthcare consumers could benefit from having an individual that is educated to be able to provide that level of care, take care of the patient on an ongoing basis, and then having the physician be able to make sure that when they see them on those follow-ups, that they have all this information that individual is being monitored, that they're being managed in terms of their chronic disease. I always tell a physician friend of mine, what happens when right now in your office, for example, you have diabetic patients, and you get a call from a diabetic patient that is having a problem, is having their blood sugar is either too high or too low. Usually it's too low. Well, that basically disrupts their office for the whole day. So basically they have to cancel appointments, right, for other patients and everything, because now they have an emergency on their hands, right? So having a pharmacist be able to monitor that and, so the likelihood of that happening if a pharmacist is managing that patient is less, because we're following up on that patient on a continuous basis. And then we can provide information to the physician of how they're doing along the way. So then when they come and see the patient, the physician, things are relatively more controlled because we would see them.
Well, the overall healthcare ecosystem has improved dramatically. And one of the issues, and I believe it's because of this insidious COVID crisis that we went through, when the public got to see the pharmacists, because they're the ones that they didn't have to go running to hospitals, they didn't have to go running to the offices. They went to their pharmacists, they got their inoculation, and they were off. And I think that played a real goal in the overall change in the relationship between the pharmacist and the healthcare providers, and it changed for, I believe, and I think I've heard it from you, for the good of the public.
I think so. I think the public got a glimpse as to how a pharmacist could respond to their healthcare needs. Pharmacists stepped up. Luckily, HHS was able to pass that emergency order to allow pharmacists to do that. I don't know what would have happened. If you think about it, what would have happened to society if pharmacists had not been able to be at the forefront of what happened during that pandemic? I don't know, because even with pharmacists, so the impact I think that pharmacists had in vaccinating the majority of the public, or a significant part of the public, was significant. And we also got to be able to be recognized by the public as a healthcare provider. We now touched the patient. We now had a sit down with the patient and were able to show them what we were going to be doing, provide the immunization, follow up to make sure they weren't having any side effects, et cetera. So I think it was a terrible thing, but it was also a good thing for the profession. I think that the public became more aware of our role and our abilities, if you will.
Well, I'm glad you said that, because I've felt the exact same way. That's why I'm so proud to have your friendship and your knowledge. Folks, we tried to get into some of these things. These were questions that you asked, and we brought to you Dr. Goar Alvarez. He's a premier pharmacy educator, and we're very proud that he is in charge of all the pharmacy services that we provide here at Nova Southeastern University, not only at the university itself, but through the community and various contracts. We appreciate you turning in to Dateline Health again. Remember, if you have any questions, you want any answers, there's an email address and telephone number right here. Dr. Alvarez, thank you very much for your time. I really appreciate it. You're a dear friend and a wonderful professional. I'm proud to be in the same profession, even though I haven't been in a prescription element since 1986. But that's the way it goes. You get older, you just get wiser, I think. Anyway, folks, thank you once more time for showing up. This is Fred Lippman coming to you from Nova Southeastern University. Until next time, see you.